Hello, is everyone here? Hi, good evening. It's Dr. Santa Anna here from the Michigan Center for Regenerative Medicine. Thank you for joining us this evening for our webinar. We actually pre-recorded this webinar yesterday because we couldn't all get together to get this done. But anyway, we'll go ahead and get started, and hopefully you guys get something out of it. I'll be around to answer any questions you may have. Okay, give me a second. Let me just.
Hi, everyone. Thanks for joining us tonight. Dr. Farhat, Tom Navity. We are pre-recording our webinar tonight. There will be an opportunity to ask questions, and Dr. Santana will be presenting and available to answer questions. But tonight's topic, we're focusing on our interventional pain procedures, the things we learned as interventional pain physicians, things that are billable to most all insurances, and we'd like to start at the basics and move you all the way through the more advanced procedures. So interventional pain is kind of the next step beyond typical thoughts that people have when they think about doing a pain management physician. A lot of times people's mindsets go towards pills. Tonight we're here to talk about everything that a pain management physician can do that doesn't involve prescribing you medications, but rather targeting pain generators at their source.
Right. So when people have an issue, basic things come to mind. So things like modalities, you do ice and heat, and you take your over-the-counters, you go to the chiropractor, you go to physical therapy. All those things are usually done before we start putting needles in people. So these are just treatments where we are actually doing an intervention to try to improve the symptoms or really determine what the source of the pain is. So our first step is to really always, like we've mentioned time and time again, is to figure out where the pain is coming from. So there's lots of theories out there as to what happens with these acute pain episodes, and most of the stuff we deal with, probably 80% is based on spine. Most of the time we have people that have a back problem or a neck problem, it's confused with a hip or whatever, so our job is to try to figure out where that pain is coming from. The procedures that we have are pretty much either target certain structures or rule those out as a potential pain source. So one of the things most everybody has heard of is an epidural steroid injection. So what is that exactly? Well, we have our little friendly spine model here. And so the epidural steroid injections can be done at any aspect of the spine. So the neck, the middle back, the low back. Probably 90% of what we do is neck or low back. Most of it is low back. So what is an epidural steroid injection? So essentially what happens is if there's a pinched nerve, either from arthritis or a disc that's herniated, we're trying to put a cortisone injection on a nerve that's getting pinched or put it into the spinal canal to allow the pain to calm down from that pinched nerve. It's usually a steroid or cortisone, some people refer to it as. We do that under visualization. So wherever we do these shots, we're always taking x-rays or verifying where this medication is going. But essentially a needle is placed into the spinal canal. Oops, those are my sunglasses. That won't work, yeah. This will work. So essentially a needle goes in here and we shoot this dye to make sure it's in the right place under an x-ray, and then put a cocktail of medication, which usually includes a steroid of some type, a cortisone, sometimes an anesthetic, sometimes salt water, or a mixture of those things. Most of the time we're trying to improve somebody's pain down their leg or down their arm. It may or may not help with the back pain. So that's sometimes the thing we have to verify, that we're trying to treat a certain part of the pain that's causing the symptom. But anyway, that's essentially what we're trying to do, is place the medicine into the spinal canal and bathe the nerves in the spinal canal that are getting pinched.
So that's the basis, I would say, for most everything we're going to talk about from here is what do we think is causing the pain? How do we use a machine like our x-ray machine behind us to very specifically, very carefully place a needle into a specific target and numb up the pain? And that can last for days, to weeks, to months, to years. And what we do afterwards just depends on how long it lasts. The epidural space being one of many targets that we'll go after. The other areas in the spine that are very commonly a source of pain are facet joints or zygapophyseal joints, which are very similar to our fingers. They move in a very similar way. They're synovial joints, just like our finger joints. And just like your fingers can get arthritis and your hands can hurt from that arthritis, so can these same joints in your back. And same idea, same concept. Very carefully drive the needle specifically towards those joints and either inject the joint itself or block the nerve that goes to that joint. Both result in pain relief that can last for a variable amount of time. Another joint in the spine, where the spine meets the pelvis, is the sacroiliac joint. Exact same concept. Target the joint on an x-ray machine, very carefully and safely watch your needle go directly into that joint, and inject a cortisone lidocaine combination and see how long it lasts.
And sometimes we use these injections to rule things out. So we may think it is the source of pain. We do a test shot, it doesn't work, so then we can say, oh, that's probably not the source of pain. We start looking for other options. Some things have more potential to cause symptoms than others. For instance, the sacroiliac joint, if somebody hasn't had surgery or they don't have hardware in their back, it's a low probability that this is the cause of your pain. But if you do have a fusion or somebody's already put hardware in your back, then this SI joint is a much higher probability of causing your pain than, say, where the surgery was done or something along those lines. So a lot of these things depend on your anatomy, your history. So half our job is to figure out what's the cause of the pain. So like Dr. Navity had mentioned, facet injection. So these little tiny joints between the vertebral segments, they can become arthritic. One option is to inject the joint. Most of what we do nowadays, though, is to do a test shot where we numb up the nerve that supplies the joint. The reason being, we're trying to determine if this is the source of pain. And again, if we can make that relief last longer, that's what we're going to do. So one of the other procedures that we do, if you get a short-term response to this facet injection, is a radiofrequency. There's different terms people use, sometimes ablation, neurotomy, rhizotomy. But essentially what we're trying to do is eliminate the nerve supply for the joint. Now, that is temporary again, but we hope for at least 6 months of improvement from that procedure. Sometimes it can last up to 2 years. If you get a good response, then we just repeat that procedure again. Now, when we say it's a quote-unquote burning of the nerve, it's not like we make any cuts. It's just the needle position that places it in the right place, and we heat up that probe. No cuts or anything. It's still just a needle. So again, this can be done at all the levels of the spine, even down here at the SI joint. This radiofrequency procedure can be done. There's some procedures too for the knee, shoulder, not so much, but mainly knee and spine.
Yeah, and the concept applies outside the spine. I mean, there's other pain sources that as interventional pain physicians we treat. Other joints, knees, correct, shoulders, hips, and there are nerves that go to those joints as well. Very similar idea. We start by blocking the joint itself, doing a cortisone shot in the joint oftentimes, or in different spaces between tendons called bursas. We see how long that lasts in conjunction with physical therapy and exercise and movement. And if that works but doesn't last, there are potentially radiofrequency options where we burn those nerves. As Dr. Farhad alluded to, the knee works the best. There are nerves in the hip, there are nerves in the shoulder, mixed coverage with insurances for those, so that's why oftentimes they're not as commonly done as the knee, which has very good insurance coverage for. And the results are somewhat mixed in the joints. The spine's a much higher success rate than the peripheral joints. But that moves us into another advanced procedure that we can use for these types of nerves outside the spine, where we can put peripheral nerve stimulators. So rather than burning and ablating the nerve, we can place little spaghetti strand-like electric wires next to the nerve with a handheld external communication device that can turn that wire on and off, which can shut the nerve down with electricity rather than with medication. So those are called peripheral nerve stimulators, and we can use those for peripheral nerves that go to joints, but also for peripheral nerves that, say, cause pain in the leg from nerve damage. There's conditions like CRPS or peripheral neuropathy that these devices can be used for.
So Dr. Navy's talking about spinal cord stimulation as well. So we have peripheral nerve stimulation we have spinal cord stimulation. It's a group of treatment we call neuromodulation. Essentially, it's a kind of a interesting concept. What we're trying to do is trick the brain. We're essentially trying to make the brain pay attention somewhere else while the pain that you're experiencing is probably still happening in the background, but the brain only pays attention to what's actually happening, the stimulation. So this group of treatment can be a peripheral nerve stimulator. For instance, I had a patient, unfortunately, had multiple knee surgeries, knee replacement, didn't work, and he still had pain, so had to put a stimulator along the nerves for the knee to help with the symptoms, unfortunately, because there weren't any other options. Another option is to put it into the spinal canal itself. So again, most of the time what we're treating here is somebody who's had surgery or failed surgery or can't have surgery or something along those lines. So we put the stimulation in the spinal canal to essentially trick the body and the brain to thinking that the pain is not necessarily there. One of the big diagnoses that we can use that for nowadays is something called peripheral neuropathy, which unfortunately a lot of people suffer from diabetes. It's a complication from diabetes. Toxins such as alcohol or chemotherapy. Some of these diseases unfortunately there aren't really any treatments for, so we use this particular treatment as sort of a last measure, let's call it. But the good news is, right, we can try it. So there's a trial period. What does that mean? So we get to put the device into the area where we think is causing the pain. The battery stays on the outside of the body, and you get to feel what it would be like for about a week before you actually have to commit to putting it inside you for good. So that's something we do. We have to get insurance approval, and those kind of things. But the good news is it's one of the only times in medicine where you actually get to try it before you buy it, right?
Yep.
So that's kind of an advanced procedure for folks, unfortunately, that don't have a lot of other options.
And I think it's a good segue into what we meat and potatoes. What we want to talk to tonight is the more advanced procedures that our clinic and the skill of our physician group has accumulated in our years of practice. These weren't things that we were taught in our fellowships and our residencies. These are all things that have evolved after we've graduated, and it's things that we've had to adopt and use our taught skill set and then learn new skill sets. But I guess one of the newer ones that's come out in the last few years that's really helping people with that sacroiliac pain we were talking about, where the spine meets the pelvis. This sacroiliac joint right down here, it's a joint that's not supposed to move in our bodies. So it
moves very, very little.
Two bones that come together, and they're really not supposed to be a lot of movement there. And when there's too much movement, laxity is the issue. We can inject it with steroid, we can numb it up, we can try to burn the nerves that go to that joint. But if we don't stop the movement, that pain's going to continue to recur. So there's a surgical procedure to place screws across the SI joint, done with x-ray guidance, very minimally invasive outpatient procedure. But by placing screws and stabilizing that SI joint, you're able to eliminate the pain that's emanating from the joint. Very high success rates for patients that respond to the diagnostic blocks, where we inject lidocaine and steroid directly into the joint, but the pain unfortunately comes back after it substantially goes away for a short period of time. Those patients selected properly do extremely well.
And there are a few different systems out there now. There's probably 10 different types of systems that do the fusion. So some of the systems are more invasive than others. We try to do the least invasive option here. So you can actually fuse the joint from coming in from posteriorly to put something in there to hold it together. And the more invasive treatment is where they actually come through the side and they put these screws along the length of the joint to try to fuse it together. Obviously that works as well, but it's a little more invasive because there's a bunch of muscles right here, and so somebody that has to do a very good job of positioning this, more surgical based than a pain specialist, but either way the concept is the same. We're trying to make this joint not move. That brings up the fact that there is a percentage of folks that unfortunately will need the other side done too, because if you stop moving this side, well, this side may move more. So I think it's around a third of the people
Yeah, it's
end up getting both sides.
common with fusion of any kind,
Yeah.
regardless of the area. When you fuse one area of the body, that movement the body wants to gain that motion back, and it will shift it to other areas. So all part of the consult, all part of the discussion, risks and benefits, and we always try to help our patients make those best risk-benefit analysis.
So these are all covered by insurance too. That's the thing. All these things that we are talking about is insurance coverage once we get approval. But these are procedures that the insurance company will cover.
Another one we want to talk about tonight, something for a condition called compression fractures.
Oh yeah.
You want to talk a little bit maybe about compression fractures and the treatments we have for those?
So what is a compression fracture? So unfortunately, again, this is part of aging process or sometimes trauma. These vertebral bones can fracture. Now, typically, it's an osteoporotic fracture, or as we age, our bones aren't as dense. So what happens is, the good news is it doesn't rupture, like blow out everywhere. What it does is just collapses. So typically, it's around the transitional point between the thoracic and the lumbar spine. These are the most common levels that get fractured. It's usually a very obvious event people can point to that happened. They'll know. Sometimes they feel like this large explosion in their back, or just a severe discomfort that happened all of a sudden. Take imaging, it shows that this vertebral body has collapsed. As long as it's not too far collapsed, what we can do is put cement essentially into the bone itself. We put a balloon in there, inflate it, and then fill it with cement to try to stop the bone from collapsing. And that usually is like a night and day difference. Like, people get on the table, they're in pain. They get off the table, they're out of pain. There's a lot of criteria for this nowadays, as far as like if it's acute versus chronic, pain source, etc. But this is a type of procedure that can actually be done here in an outpatient setting. It doesn't have to be done in a hospital. And people walk out that same day without any major issues.
Yeah. So sounds like a big procedure, but like you alluded to, it's outpatient, done through tiny poke hole, through a needle, and done safely with the assistance of X-ray guidance, and it works almost immediately. That cement is quick drying and stabilizes that bone that's otherwise compressing.
Yeah, unfortunately, it's usually older, thin women that get these compression fractures because of the bone density. But even in traumas, young people in a car accident, for instance, can unfortunately get a compression fracture because of the forces involved in a car accident. So it is a procedure with a skilled hand. It's pretty easily done with minimal complications. So.
And then the last procedure I had on my list to discuss tonight was treating discogenic pain and smaller disc herniations with minimally invasive discectomies.
Right. So used to be that you had to have a surgeon sort of go into the spine and take the piece of disc that's herniated away from the pinched nerve, or remove some of the bone in the spine to get some room for the nerves. But if the disc herniation is small enough, we don't have to do that. We actually do that procedure through, again, a small needle puncture that goes into the disc and tries to decompress the disc. So typically 5 millimeter, 6 millimeter herniations that really may even be able to improve on their own with time, but sometimes don't. We can go into the disc and sort of take out material to sort of shrink the size of the herniation from inside, instead of taking pieces of disc material away from the outside. It's a pretty straightforward procedure, minimally invasive. Again, covered by insurance. So most insurance,
Yep.
right?
Yeah, no, it's not one that's difficult to get approved, as long as you've gone through. There's usually hoops that you got to jump through. It's not and it shouldn't be the first treatment option.
Right.
There's treatment options that are less invasive that, unless it's some urgent indication, should be tried first. And if those fail, then
Right.
we move forward with this, and that's appropriate.
So usually we would try an epidural steroid injection if it's short term, it doesn't work at all, etc.
Yep.
And in fact, I actually just talked to a surgeon today that informed me that most disc herniations, especially older folks, they don't even take out the disc. They just make a laminectomy. They just sort of make room for the nerve and let the body sort of heal over time. So this concept of we want to do the least invasive insult to the body to allow it to heal. That's kind of what we're trying to do.
Well, we hope you found this informative. There will be an opportunity for questions. Dr. Santana will be there to answer your questions. If you heard anything tonight that maybe you or a loved one you think might be able to benefit from, by all means, please give us a call. We'd love to schedule a consultation to see if it's something that we can alleviate pain. Michigan Center for Regenerative Medicine, also Michigan Center for Pain Management, 248-216-1008.
So we had a really nice presentation with Dr. Farhat and Dr. Navidi. We're going to go over options for pain management. So when we talk about pain management options, it's a pretty broad topic. So when we talk about interventional pain, we like talking about more advanced procedures outside of your typical pain medication type management. We all know that pain medications have their purposes, but unfortunately they're not that great as far as dealing with your day-to-day functions. All they do is they mask the pain, and even then they don't do a good job of doing that with the medication. So it's an option, but it's like a treatment option that we would use as a supplement, but not the main course of treatment. So when we talk about pain management, one of the primary techniques that we like talking about would be injections and nerve blocks and things like that. So for somebody who has pain, typically the way that pain is transmitted by your body is through electrical impulses in your nerves. What we would do in our techniques is we do these image-guided injections of specific nerves where we can block the pain either with an anesthetic or steroids or a combination of both. So that's probably the most common pain management procedure that people would do. So typically would give these injections inside joints or around nerves or around muscles and things like that. Moving forward from that, we can be very specific as far as where we address the pain. So most of the pain things that we see are, let's say, in your spine. So the next step to that would be something called an epidural injection. So this is an injection into the spine where we know that your nerves transmit pain signals. By putting the combination of the anesthetic and steroid into that spinal canal where your nerves are, we're able to intercept those pain signals in the brain and give you relief from your back pain. So, for example, if somebody has a back issue where they have a herniated disc or arthritis in the lower back, when we perform these epidural injections with X-ray, the idea is we put the medicine into that part of your back, which can relieve a lot of the irritation around the nerves, and in turn helps a lot of the back pain and nerve pains that you may have. The other types of treatments that we like talking about is something called the spinal cord stimulator. So the spinal cord stimulator works on the premise by how your nerves transmit pain signals, and your nerves transmit these pain signals through electrical impulses. By intercepting these electrical impulses by these devices called stimulators, it's essentially a small device that's essentially made up of two small wires with electrodes in them. And what we do is we place them in your spine. We do it through a needle. So everything is done through the X-ray, so it's very safe. And these wires are connected to this battery pack, which helps modulate how much of those pain signals are transmitted by your nerves in your spine. So it kind of creates that barrier between the transmission of pain in your body and to your brain by that implant in the wire in the spine. So the nice thing about the stimulator is that we use it for a lot of cases, not just for your run-of-the-mill pain, but we could also use it for patients who've had prior surgeries before, because it doesn't matter where your pain is coming from, whether it's from nerve pain or arthritis or from a surgery, it's just going to block the pain. The other nice benefit of it too is that we do a trial of it first. So that means that we do the placement in the office. It takes about 40 minutes to do. You go home the same day and essentially take the device for a test drive for about 7 days. And you come back in 7 days, and then we pull it out. In those 7 days, if you had really good relief, that's the only time that we would place the device in you permanently, or we embed everything under your skin. And you'll be able to control it with a handheld device. So you can turn up the blocking under stimulation, or you can turn it down as much or as little as you need it. So it kind of grows with you too, because as your pain changes, because this is already implanted in your spine, we'll be able to control how much of that pain gets transferred also. So it's a really nice treatment for somebody who has chronic pain that's there all the time, that doesn't relent and always there. I like the analogy of chronic pain as being like a really loud noise in your radio, like a really loud music in your radio that you're driving that you don't like to hear. So what the stimulator does, it essentially turns down the volume of that loud radio, which is your pain. And it doesn't, in some cases, it can relieve almost 100% of the pain, but in most cases, it relieves it enough that you're able to kind of go through your day-to-day activities without having to deal with pain. So that's a nice thing about it. There's really no, it works instantaneously, and then there really is no side effects. Again, because we get to see how it's going to help you from that trial. The next evolution to that would be something called a peripheral nerve stimulator. So very similar to a spinal cord stimulator, a peripheral nerve stimulator essentially blocks the nerves in the extremity. So instead of it being implanted in your spine, it goes to a specific nerve that targets a specific part. So let's say somebody who has chronic knee pain, or ankle pain or neuropathy or something like that, then these peripheral nerve stimulators work really well, because it's targeting a very specific area where a spinal cord stimulator usually covers a bigger range. So there's applications for everyone. And same thing, we do a trial of it first. We'd see how well it works for you, and then if it's effective, then that's the only time we will do the permanent treatment. The third thing I want to talk about is something called sacroiliac joint fusion, or SI joint fusion. Another main source of back pain would be sacroiliitis, or SI joint pain. So typically, a lot of the times we would treat this with injections, and which works fairly well. But there are times when the injections don't last as long, or doesn't give you that sustained relief that we're looking for. So the evolution of these SI joint fixations or fusions have evolved, and now we can do them in the office. The idea is your SI joint is a joint where your pelvis meets your spine. It's a true joint, but it's not really meant to move like all the other joints in your body. It's actually just meant to be still. When you have excess movement or excess play in that joint, that's when you have that pain. And what we do is we fuse it with, we use a very specialized screw to kind of put it into that joint. So it's a pretty invasive procedure, but for somebody who has chronic SI joint pain, that could be a solution for them. So that's something that now insurance allows in the office. Excuse me. And then the other thing that we were talking about would be your radio frequency ablation. So that's another treatment that we like to discuss. It's essentially, radio frequency ablation is when we would essentially burn off the nerve. So the way we talked about how pain is created is with your nerve sending these signals of pain. So once we're able to identify that, we can do a test where we would block the nerves with an anesthetic to see how much of your pain is going to get better. And if it does, then we can do a nerve ablation. So the nerve ablation is pretty straightforward. What we do is we put a needle in there that is hooked up to this machine, which heats it up at a certain temperature. And in essence, it kind of denatures the outer covering of the nerve. So it creates something that we call a conduction block in the nerve, and it blocks that pain a good deal. So for somebody who has, again, chronic pain issues, this is a good treatment where we can try and blocking it, and then we can do the nerve ablation. And that nerve ablation typically lasts about a year or so, give or take. So these are all good options to try. I know a lot of these things are kind of geared towards the spine, but we have evolved and used these treatments also in the joints and also in the periphery. So it's not just into the spine. I have to apologize again. This wasn't how it was supposed to be planned. I know they had a really nice outline and template of their discussion, but we kind of had to wing it because of some technical difficulties. As you can tell, I'm not very good at this computer stuff. Okay, let me go through some questions here. So for Pat, the question is, how long do these interventions work? So it depends. So when we talk about injections with steroids or anesthetics, they typically last a good 1 to 3 months. When we talk about these other interventions, like the spinal cord stimulator or peripheral stimulator, those can last as long as you need them to be, lifelong, because they're going to be implantable devices in there. And as long as they're working, it should continually block that pain for as long as you need to. Things like the radiofrequency ablation, those ones, they last roughly about 8 months to a year is what I typically see for my patients. And then after that, when it wears off, we can always do the injection again or do the ablation again. So it's something that you may end up doing yearly, but for the long time, it should help with the pain. Let's see. Rhonda asks, does any of this work for neuropathy? Yes, actually, for neuropathy, the spinal cord stimulator and peripheral nerve stimulators are options that insurance do approve for these types of things and should be able to cover those treatments. What we'll do is there's a few things that we have to check the box with insurance, but that's something we can discuss with you when you come into the office. And then Jeff's asking, are these all covered by insurance? And yes, these treatments that we wanted to cover today are all covered by insurance. So the nerve stimulators, the SI joint fusion, the radiofrequency ablation, these are all covered by insurance. I have tried these and found peptides. Yeah, that's true. So that's one of the things that we pride ourselves in our clinic, right? So we're not just we have a lot of tools in our toolbox. We have tools where your insurance will cover it, and we have tools where insurance doesn't cover it. So it's not a one size fits all. Everyone, we kind of tailor the treatment to what everyone needs. So whether it be regenerative medicine with prolotherapy or PRP or stem cells or these nerve blocks or the stimulators, we can go over all these options with you. Ben asked, do you perform C0C1 PRP prolotherapy? So C0C1 is a very highly technical technique to do. So Ben is asking about the upper portion of your neck as it joins with your skull. We don't. The highest that we would do would be C1, C2. For something like a C0C1 injection, I would probably have you see somebody from U of M or somebody like that in a more or Mayo Clinic or something like that. Let's see. Can the ablation be done in conjunction with the stem cell injection in the spinal column? Yes, it can. So the ablation treats different portions of the spine. Same with the stem cell procedure. Ideally, if the stem cell procedure is going to take care of all of those issues, but sometimes we know that it doesn't. And then, we can complement those stem cell injections with the ablations also. Teresa asking, the consultation, yes, is going to be with me, Dr. Nabity, or Dr. Farhat. All three of us are board-certified physicians in pain management and physical medicine. We have been doing this for a long time. And I would say we have the most experience in regenerative medicine in this area, combined with our experience in your typical pain management arena. We should be able to kind of give you good options for that. Paul is asking about, do you do Wharton's jelly? So we do not, Paul. We found that for our purposes that Wharton's jelly is something that we haven't found to be more effective than what we do with autologous stem cells. You have to remember that Wharton's jelly and all those birth products are essentially dead cells. So, for the purposes of orthopedics and trying to rebuild tissue, you want cells that are going to be alive, and Wharton's jelly is not. The other thing to consider too is that Wharton jelly injections in orthopedic conditions are not FDA approved, and the FDA is cracking down on clinics who offer Wharton's jelly or umbilical cord cell injections for musculoskeletal, spinal, or joint issues. So that could be a dangerous ground to deal with. But definitely do your research, Paul, before you kind of jump into that. Let's see. Patty, are stem cells covered by insurance? Unfortunately, not. What we do is we are able to bill your consultation through your insurance, but if it does come to a point that the treatment is a stem cell procedure or something like that, then that will not be covered by the insurance. I've had stem cell injections 3 or 4 years ago. I have pain and cramping in my knees and legs. So it can happen. So you have to remember that when you've had injections with stem cells or PRP, it does kind of revert it back to when it was better. But over time and wear and tear can still happen. So it may be that there's some degeneration that's occurred there. But then your knees will be a lot different than they were before you had the procedure. So there might be something that would respond to a simple knee injection and then kind of just reset everything again, and you should be back to normal. Okay. Rhonda's asking, can stem cell help for neuropathy? Right now, we're not treating neuropathy with stem cells. That's not the focus of our clinic. So it's not something I could comment on because it's not something that we do. Angel's asking, what are the risks? Are there a sequence of trying different techniques? If you block nerve, what happens to the process? That's a good point. So unfortunately, with the realm of insurance, there is a sequence that we have to follow. So in order for insurance to approve certain procedures, there is a route that we have to follow in order to get things approved. Unfortunately, that's just kind of how the game is played. But we still want to make sure that that's appropriate. So we don't just follow the pattern blindly if we know it's not going to be beneficial for you. And then for your next question, if you block the nerve, does it affect degeneration? It doesn't. So the nerve, the issue is still degenerated. We're not really fixing anything. We're just addressing the symptoms of pain, not really the source of it, which is the degeneration. For treating the degeneration, you're better off doing regenerative medicine for that. Ben is asking, do you perform dextrose prolotherapy and ultrasound or fluoro? The answer is yes to both. We do both of those, and we go all the way up to C1, C2. Glenn went to Mexico for stem cells. I'm glad to hear that. Yes, but I want to let you know that we're also here in Michigan, and we could probably save you some for that trip. But I'm glad that it's working well for you. Do you offer hyaluronic acid? We don't offer hyaluronic acid injections in the knees before. Unfortunately, it's something that we don't offer anymore. So I can refer you to other clinics in the area that does. Are insurance covers PRP? Are these billed by your office? So insurance typically does not cover PRP. The only insurance that covers PRP is TRICARE, which is for the military, and they are very specific for knee arthritis or elbow arthritis. So if it is something that you have benefit to with TRICARE, then yes, we can bill that to our office. How does PRP help with meniscus tear? That's a really big topic, but short answer, it works really well for meniscus tears. Depends on how big it is. So if it's not too big, PRP works really well for that. And then in-office sedation, we do IV sedation with a nurse anesthetist. It's a twilight sedation, nothing general. Let's see. Do you find nerve procedures improve function? It depends. So if the nerve issue is preventing you from being able to function well, then yes. But if the nerve is the issue that's, let's say it's not firing well and that's why you can't walk, then no, it doesn't work that way. Can you treat occipital muscle tear with C2 spinous process? Yes, we can. And Ron just asked, do you take Humana? Yes, we do. Okay, so I think I've covered most of everyone's questions. Again, I appreciate everyone kind of hanging in there with me. If you have any other questions or would like to schedule an appointment, please call our office. It's 248-216-1008, and we'll go over any question you may have, and hopefully we can help you guys recover your life back and help some of this pain. Okay, good night, and take care.